Hello, everyone, and welcome to the Learning Lab event on troubleshooting social needs screening lessons from the field. My name is Emily Noodleman, and I am the Transformation and Community Partnership Manager at the Foundation for Healthcare Quality. In my role, I primarily support the Bree Collaborative Program and the implementation of the reports into practice, and also support the Foundation's health equity work. Today, we are thrilled to have each of you join us and engage in this event as we work to explore how the Bree reports and Foundation's social need and health equity reports can be implemented into the healthcare ecosystem and ensuring that equity is centered within our implementation efforts. One moment. As we begin, we just wanted to review some items with you all. Please place any questions you may have in the chat box. There will also be an opportunity for you to come off mute and ask questions if you would like to our panelists during our Q&A section of our webinar today. Please ensure you are also on mute, and we will be recording today's presentation and plan to post it on our website sometime next week. We will send those who signed up for the event the recording of today's event. As we begin, we have a couple of items we want to review. The Learning Lab event has been approved by WISMA for individuals to attain CME credits. The CME credits are available to claim for individuals who are attending the live event only. Unfortunately, we are unable to provide CME credits for individuals who watch the recording. To receive the CME credits, please complete the post-webinar survey, which will be linked at the end of this event, and we'll also mail out the link to you all as well. Once you submit the post survey, you will see a screen that looks like this. Click on the hyperlink under the word "Here" to be taken to the CME credit claim form. I will plan to follow up with you at the end of this month with the certificate of your participation. No one in control of content has indicated a relevant financial relationship with an ACCME-defined ineligible company, also known as commercial interest. All clinical content presented will be evidence-based and unbiased. The agenda for today's event is to provide a short introduction to the Bree Collaborative. Then we'll hear from our speaker, Kylie Kingsbury from Chaz Health, followed by some time for Q&A with our speaker. We will then transition to a dedicated time to engage with peers and connect with peers across the healthcare ecosystem in a facilitated small group discussion. We'll come back as a group and wrap up today's event. The learning objectives for the Learning Labs are to identify how a Bree or Foundation Healthcare Quality Guideline can be implemented into practice settings, recognize how social drivers of health can impact a person's overall health status, work to plan or modify strategies to center health equity into quality improvement initiatives, and to engage with peers working throughout the healthcare ecosystem who are in attendance today. As a brief introduction to the Bree Collaborative, it was developed in 2011 by the Washington State legislation so that public and private healthcare stakeholders would have the opportunity to identify specific ways to improve healthcare quality, outcomes, affordability, and equity within Washington State. These stakeholders are appointed by the governor and work as collaborative members. They represent public healthcare purchasers for Washington State, private healthcare purchasers such as employers and unions, health plans, physicians, and other healthcare providers, hospitals, and quality improvement organizations. Each year, our members work to identify healthcare services with high variation in the way that care is delivered, that are frequently used but do not lead to better care or patient health, or that have patient safety issues or inequities. Once a topic is identified and chosen as a focus for the next year, the Bree Collaborative forms a work group of subject matter experts to develop the report that provides information and guidelines for actions different audiences can take within the healthcare ecosystem to improve the care for that topic. On your screen, you can see an example of one of our guidelines. We recommend in a handful of our reports, such as the Bree report on diabetes care or our report on perinatal behavioral health, for health systems and plans to screen for social needs. This on the screen is an example from our perinatal behavioral health report. You can see we ask for organizations to screen every pregnant or postpartum person at their initial prenatal visit, later in pregnancy, and postpartum visits for social needs. But how can we implement this guideline in practice? How may this look? We do, as part of our foundation, have a report on social needs screening, which provides further guidance on this and social need intervention. However, this is none of how to implement the social needs screening is what we will hear from our speaker about today, how they are at their organization working to support the implementation of the PRAPARE model. So I am really excited to invite Kylie Kingsbury to come forward to speak on the work that they are working at Chaz Health on. Kylie is the Health Equity Manager at Chaz Health and has worked in public and community health for the past 11 years. In her role at Chaz, Kylie leads the community health workers team and manages the organization's social drivers of health programs that support the health and wellness of Chaz patients. With a background rooted in community-driven solutions, Kylie works to ensure the Chaz Health Equity Department is striving to meet the diverse needs of communities they serve. And we'll welcome Kylie.
Hi, everybody. Excited to be here. Thank you, Emily, for that introduction. And so Emily shared a little bit about kind of what I focus on in my work at Chaz. And I think PRAPARE and our social needs screener is the perfect combination of both worlds of our SDOH work and our community health workers. And so I'm excited to kind of share how we've rolled out our SDOH screener across our Chaz clinics. And I'm hopeful that some of that information that I share with you all here will be helpful and kind of useful in getting started or troubleshooting some of your SDOH work. Next slide, please. So a little bit on Chaz. Chaz is a federally qualified health center in Eastern Washington and North Central Idaho. You can kind of see it on the map there. We currently have 26 sites, and we offer medical, dental, pharmacy, urgent care, and behavioral health services. In addition to those, we have several school-based health clinics that are located in local elementaries and high schools in the Spokane area, and several mobile units. We have some up in the Washington, Spokane area, and then southeast corner of Washington, and then in central Idaho as well. And those offer services to communities that have limited access to healthcare where we don't have brick and mortar locations. And so Chaz Health started in 1994, so a good chunk of time ago, in a small office in downtown Spokane, and now have just progressed and moved into opening clinics across in the Northwest. Next slide, please. So to give an idea of what sorts of patients we're serving at Chaz, I think it's helpful to kind of think of our Chaz patient population as a community of 100 people. And when you're looking at that, 79 of those 100 people would be below 200% of the poverty level. Of that 100, 10 would be uninsured, 22 would be experiencing homelessness, 17 would be a racial or ethnic minority, and then 5 would be served in a language other than English. Next slide. So as an organization, we recognize that our patient health outcomes are significantly impacted by factors that cannot be addressed by traditional medical care. That understanding has led us to collect data to better understand our patients and the social drivers of health that are impacting their health and wellness, including housing instability, food insecurity, lack of transportation, among others. So at Chaz, one of the primary ways that we do this is through our SDOH screener program. And we utilize the PRAPARE screener to identify SDOH risk factors. And then we have our community health workers, and you can see the photo of a handful of them on the right. And so our Chaz community health workers use those screeners as a guide to support patients in addressing those SDOH needs. The process is an integral part of our work at Chaz to provide equitable patient-centered care that addresses this full spectrum of patient health needs. Next slide. There we go. Perfect. So a little bit of background and history. So we started using PRAPARE at our screeners in 2019. And since then, a lot has changed. And it looks very different than when we first started in 2019. But we had really strong support from our Chaz Health Board and our executive leadership, which made this process a lot easier and allowed us to dedicate staff and resources to this work. And I think I personally am appreciative of that early adopter work. And I think before it was the work started in the very early stages, I think, of when screeners were being talked about in health centers in our area. And so one of our core values at Chaz is patient-centered care. And so our prepare work is part of that, is that core value in action. And so I'm going to dive in a little bit deeper now on like what it actually looks like at our clinics. So this kind of design shows what it looked like back in 2019 when we had our first workflow. And so patients were completing the full prepare screener in the lobby when they were checking into their appointments. And after they would check in and complete the prepare assessment, we had medical assistants that would reconcile the screener from our check-in system up front in our clinics, which was an iPad, and they would reconcile that to the EHR. We use Athena at Chaz. Then, based off of the answers that were in the prepare assessment, they would create referrals to the appropriate teams to address the SDOH needs that were identified in the prepare screener and the answers. And so you can kind of see in this graphic that there were several teams. So we had some questions went to the behavioral health team, some questions went to our community health workers, some went to our PRC team, which is patient resource coordinators that help with like insurance navigation and payments for medical care. And then we also had some specific other programs. So it was kind of a hard process to keep track of where referrals were going. And each question in the prepare assessment was linked to a referral route, and there were 21 questions. And so you can kind of get an idea of how complicated that was for our medical assistants. So in this existing workflow, there were a couple points in the process where things could get really held up or delayed. For example, we would have patients who sometimes ability to use technology in the iPads was maybe not as, they weren't as fluent in that technology. And so it was harder on the iPad to like click through or there was just varying lengths of time that patients would take with this. Then on the back end behind the front desk, the MAs, our MAs at Chaz are very busy. They have lots of different things that they're working on, and sometimes the reconciliation piece could get missed because they had a lot of other work that was going on, and it took a long time to reconcile the questions. And so in the end, this really, some of these kinks in the beginning impacted our ability to address the SDOH needs that patients had completed, or the SDOH needs that were identified through the completed screeners. And so what we did was we decided to, we made a strategic decision to pause the work, and we had a prepare group that had worked in the initial rollout that was really gathered again, and that group met to collaborate and reevaluate this workflow. And we brought together all of the different teams that were being impacted. So you had MA representation, you had front desk, our apps. So the teams who were working on the software all came together and worked to simplify those steps and to create a more patient-centered plan that both ensured efficiency and comprehensive support for our patient SDOH needs. Next slide. So now this goes into phase 2. So we rolled this out in the beginning of 2023 with a PDSA, which is a quality improvement model that we use here at Chaz that stands for Plan, Do, Study, Act. And so we did that PDSA at a single clinic. And since then, we've expanded this model across medical providers or for medical providers across Chaz. So in phase 2, patients complete a pre-screener question during their appointment check-in at the clinic, and the MA then reconciles the data and then completes a single referral to the community health worker team. Then a community health worker would contact the patient. And then, so big changes in this phase 2 are that we have a pre-screener question. And so it's a single question that's being asked instead of the full PRAPARE screener, the 21 question screener. And we're directing all of our SDOH referrals to a single team instead of the several before. So in the next slide, we'll go a little deeper into that process. So we have up at the top, so the patient checks in with their appointment, completes the pre-screener. If they say no to the pre-screener, then the MA reconciles that answer and then the process ends there. And then we have, if the patient answers yes and identifies social needs, then the MA reconciles that patient answer. And then the MA completes the community health worker referral, and the CHW receives that referral and then contacts the patient, and they complete the PRAPARE screener with the patient. And then based off of those answers, they work to address those or connect the patient to community resources. And then that is the second route for completing the referral. So if the community health worker isn't able to get in touch with the patient on the first try, they will call again within the first 5 business days. And then if they don't get in touch with them, they will send a letter to the patient that includes resources and routes to get in touch with the community health worker team. So we found that this process simplifies the workflow from beginning to end and has made things much more efficient. So right now on our PRAPARE team, we have 4 community health workers that are assigned to clinics, and they're able to complete warm handoffs with the MAs and the providers. So if a patient responds yes to the pre-screener in the clinic, the MA or the provider will bring the patient to the community health worker on site. Usually it's just like a connected or nearby the MA station, so it's pretty easy. And then the community health worker will meet with the patient and complete the pre-screener in person after their medical appointment. And so the goal for our team is for the community health workers to respond to all of our PRAPARE referrals, whether it's in person with a warm handoff or it's through our EHR. And so the goal is to respond to those within 5 business days. We have an Excel spreadsheet that tracks where we are in this process. We found that that was kind of the best way to keep track of all of the referrals that we are getting. And so it tracks where the community health workers are in the process of receiving the referral, first contact, second attempt, and then letter. And then there's options they can pick for outreach outcome. So what happened when they were able to get in touch with the patient and if they completed the PRAPARE assessment and what sorts of SDOH needs they supported with. So I'm going to go a little bit more in depth for our pre-screener questions on what that includes. And when we were first doing this, we couldn't really find very many examples. We looked online and we had tried reaching out to other health centers in the area to kind of see if anybody had come up with anything similar that we could kind of model it off of, and we did not find anything. And so we came up with these ourselves, and it was part of our phase 2. And so We first started with version 1, which had 2 pre-screener questions. So do you have any barriers preventing access to healthcare, transportation, food, housing, and or safety? And then the second question, would you like to get scheduled with a Chaz staff member to discuss available resources? So we had a lot of issues that came up during this first version of our PDSA where we were rolling out phase 2. We had patients who would answer no to the first question and then yes to the second question. And it took like, we did not think of that when we had 2 questions. And the original workflow was if the patient said yes to number 2, well, first, if the patient said yes to both, then we would, the MAs would create a referral, but then they would have a no and then a yes, and then the MAs were like, what the heck do we do? And it was something we definitely didn't plan on happening or expect. But that's the the perk of doing PDSAs and kind of experimenting. And by testing it out with our patients, we figured out that there needed to be some improvements there. And so it was also, in addition to the confusion on the yes and the no, so there were some patients who, the patients who said no to the first SDOH question and yes to the contact question, we called them because they had requested somebody to give them a call. And so some of those patients reported that they just wanted to see if we would actually call because we said they would, or we said we would, or they had questions about their medical care, or they just wanted to schedule some appointments. We were able to help with these requests, but we pretty quickly figured out too that it wasn't the most effective use of our community health workers' time, and that we really wanted to hone in on focusing on SDOH needs, and not all of these other like administrative tasks that were coming up. We also had a lot of patients who were, during check-in, shared with our front desk staff that they were confused by the question and didn't understand what we were asking. And that information was also shared with our work group. And so our community health workers also experienced that. The community health workers would be calling patients, and it was usually pretty soon after, and they would have no clue what questions did I answer? There was just a lot of confusion on what was actually happening. And so we took these issues and came up with a new question, which is over on the right. So would you like someone from Chaz to call you and talk about problems you might have with getting healthcare, transportation, food, housing, or feeling safe, and help you to find resources? So we simplified the language a little, cut out barrier to problem. We found that barrier is a word that we use a lot internally at Chaz when talking about like our population and patient population, but patients themselves didn't really understand what that meant. We also cut out the word access because we found that was confusing people, and we changed scheduled. Would you like to get scheduled? Because some patients also thought it would be like an appointment, but it was really just a phone call. And so we edited those. We ran the question by our community health workers to see if we could get any feedback from them. And then we also ran it by our Chaz Patient Advisory Council to see if we could make any adjustments to the question that we came up with, and that process came up with version 2. So we're currently using version 2, and I think, well, it has words that are more commonly used, and it's definitely more clear than the first version, but it's still not perfect. I think it's a little too long, but it's hard to really identify what to cut out because we thought it was really important to give some examples of things that that we could help identify or we could help address. And so I'd love to hear. I'm always kind of keeping an ear to the ground if another health center is using something that works really well on that note. So on the next slide, So this is what it looks like for our patients when they check in for their appointments. One barrier that we're still working on is that the pre-screener question is still only available in English in our check-in system on our iPads. And so hopefully eventually we'll be able to add additional languages so that it doesn't need to be translated in check-in or during the check-in process. And then next slide. So talked a lot about kind of the nuts and bolts of our workflow for the screener. But I think the real glue that holds this whole process together is our community health workers. And I think I'm a little biased, but I think it's one of the best things about Chaz is that we have a really excellent community health worker team. And so we define our community health workers at Chaz as trusted community members that advocate for others, engage target populations, help people navigate the healthcare system, and works to reduce the barriers of health and wellness for the community. So at Chaz, we have community health workers that are assigned to specific locations or target demographics or patient populations, and they work in clinic spaces. So they're with the clinical staff and also non-clinical spaces. So we have some that are in our admin buildings, and then we also have some that are located in community spaces like resource centers. And so we really could not do this work without them. And I think having the community health workers be a part of our SDOH screening process really allows for us to use staff who have that expertise in SDOH navigation and support, having them connected to the screener so that we can collect the information, yes, but also address the needs that come up with them so that we can really be patient-centered in that way. So in the next slide, I have it's a fun opportunity for me to brag about the great team that we have working on PRAPARE. And so these are we have 10 of our community health workers are focused on PRAPARE. And so we have our top 4 on the left. We have these community health workers work in our admin location, and they're our centralized community health workers. And so they respond to referrals that come from all of our Chaz clinics, and they're kind of like the generalists. They work to build knowledge and understanding of all sorts of resources that come up, and they lead the work of our PRAPARE referrals that come to our team. We have Candy there, and she speaks Spanish, so she works with a lot of our, with our referrals that come in with patients that are Spanish speaking, so she can work directly with them and kind of tailor the supports that she has based off of those cultural needs. And then the next 4, we have community health workers that are clinic based. And so we have one based in our Latah clinic, and then one in our clinic that specializes with senior patients, and then one in our Deer Park, and then one in our Lewiston Clarkston area in it's kind of borders that, or it's right on the border of Washington and Idaho. And then our newest additions, so we've been able to pull in some of our other community health workers that are population based. So you can see Betlin and Oksana down there. Betlin responds to our Marshallese referrals for PRAPARE, and then Oksana does our Russian speaking patients that come through the PRAPARE process. So the community health workers receive the PRAPARE referrals through our EHR or the WARN handoffs from the clinical staff, and then they connect with the patients to do the full screening like I shared earlier. Then once they complete the PRAPARE screener, they use that to kind of guide the next conversations of connecting them to resources. In these conversations that the community health workers have been having with patients, we've had a lot of needs that are identified. in the screeners. And so at Chaz, our biggest SDOH needs are housing, food, and transportation. I'll go in a little bit more in depth on how we figured or how we were able to gather that information, what our SDOH, our highest SDOH needs are. So I'll on to, or go into more depth in that in just a little bit, but by using the PRAPARE screener as kind of like a conversational tool, our community health workers have identified some pretty unique needs, some SDOH needs that were impacting patient health that I really don't think would have been identified if we weren't asking these PRAPARE questions. So I have a couple examples. One, we had a patient who had been sleeping on the floor of his home because he didn't have a bed, and laying on the hard floor was really impacting his arthritis. And through conversations, the community health worker identified that that was a need just by kind of asking some follow-up questions to the screener. And through the support of our Chaz Health Foundation, they were able to work with them to purchase a bed for that patient that fit in their space so that they could get a better night's sleep. A community health worker was working with another patient recently to access affordable internet so that they could actually attend their telehealth appointments, which isn't one of the PRAPARE questions either, but came up in conversation from PRAPARE. Then in another PRAPARE interaction, one of our community health workers learned that a patient didn't know how to read or write, and then was able to connect to add a note in the patient's chart in Athena, and to note that and share that information with the patient's care team so that they could adjust their communication plan or their communication with the patient going forward to ensure that they had all the information that they needed related to their care plan. So we our community health workers at Chaz do a really excellent job through this work, and I think in a lot of ways it's pretty fulfilling. And so I'm going to share a little bit more on how they connect patients to resources in response to the screener. So next slide. So one tool that our community health workers use to support resource navigation is Find Help. Find Help is an online resource directory platform that we use, and it helps our team to identify resources. You can go in and search specific zip codes and keywords, and then they're able to share those resources with patients that they're working with through either they can print the documents, they can text information, or they can send emails. And so another portion of what our community health workers who specialize in PRAPARE, a portion of their workday is also dedicated to connecting with community-based organizations that offer services that are free or reduced cost to community members. And so we work on developing relationships and partnerships with those organizations with the hope of doing of facilitating closed loop referrals, which is another feature of Find Help, is that you can send referrals back and forth from community organizations to another. And the community health workers also work to learn more about all of the services that these community organizations offer, so that when it comes up in patient interactions, they know who to refer the patients to. Often our community health workers are working with patients that have so many needs and barriers getting in their way, and it can also be hard to work on certain SDOH needs that are really difficult to address. And I think one of our biggest ones that we see that is really just like an uphill battle is housing. The housing market is in the inland Northwest has drastically changed over the last few years, and it's made it really hard for patients and just community members to find affordable housing. And so we have really long wait lists, and there isn't a lot of funding available in the community to support people who just need maybe even just a little bit of money to make sure that they can pay rent. And so we've brainstormed with our community health workers on our ideas to help patients who are housing insecure when there aren't a lot of resources to help. And some of the ideas that the community health workers came up with themselves are pretty awesome. So one is that they've been talking through patients or talking patients through various other kind of expenses that are on their plate, like utility bills, and then connecting them with resources to help with those so that there's some potential to open up where money can be saved in some areas and then redirected towards housing. They've also been connecting patients that are at risk of housing to community advocates so they can learn about their rights as renters. We're still working on this day by day because it changes a lot, and it's a really difficult one that we come across pretty often. And so you can imagine when you're talking with a patient who's talking about experiencing homelessness or like fear of losing their apartment, that it can be pretty emotionally impactful. Just listening to the story and trying to figure out how to help. And so because of that, we've been really focusing on self-care and work-life balance on our team. At our monthly community health worker team meetings, we have regular updates on tools or techniques that our community health workers can use to support their own wellness and self-care. And then we also do a lot of training on models or techniques that our community health workers can use in their work in general. For example, we just did one that was on strength-based approaches, which can sometimes like just a shift to finding some positive or strengths can really help when it gets hard. Okay, on to the next slide, which is something that I'm really, really excited about. And it goes into our data. So this is one of the newest components of our work with PRAPARE at Chaz, and our wonderful data team created this for us. And this allows us to look at the data that's collected through our PRAPARE screeners. Really excited about how it's very new, but we're looking forward to how it will inform our strategic planning, our SDOH programming, and all of our equity work here at Chaz. Plan to use it to highlight disparities within patient populations based off of demographics or location, and then use that to direct kind of outreach work and community work to increase partnerships with organizations that provide those services. Also, it identifies some areas for improvement. So if you look at the top left, you can see that 45,000 pre-screeners have been completed. Of those pre-screeners, you can see the next row is 38,000. That's the number of patients that have been screened. So some have been screened twice. Of those 45,000 pre-screeners, 3,400 referrals have been completed, meaning they answered yes to the pre-screener question. And of those, our community health workers were able to get in touch with 1,400 of them. And of those 1,400 visits, we've had 481 fully completed assessments. So this dashboard has identified a lot of ways where we can improve. For example, we did not realize that so many of our PRAPARE assessments were incomplete. And so it limits our data collection because you can't have a full PRAPARE score unless the whole PRAPARE assessment is completed. And some patients were like, I don't want to answer this question, or we weren't able to complete the whole assessment. They didn't have time, or various other reasons. And so it's been helpful for us to know that so that we can kind of work through some strategies to increase those numbers. Another really cool piece of this is that we're able to look at specific demographics like language or gender identity, and you can kind of look through those that are available. And then we're also able to look at zip code. Another kind of like new frontier for us at Chaz is that is the use of Z codes with community health workers. And so we're just starting that work, and it will be kind of fun to track how that improves over the next couple of years. We have a staff who has created this, who works in our health equity PRAPARE work. And so if anybody has any questions on the data piece, I'm not the right person, but I could connect you to the right person. Then next slide. Almost to the end. So now that we have some data on the work, we have a lot of plans to dig deeper into that data to see what we can find, like what communities are most impacted in our area by SDOH needs. What disparities do we have in our patient population related to their SDOH needs? The list goes on and on. Like, there are an infinite amount of things that we could figure out with that data. And so I'm hoping that our dashboard will also identify other areas for improvement for our clinical staff as well as our community health worker teams. And then so the next big step we're talking about here at Chaz is expanding our PRAPARE process beyond just our medical providers and including our dental and our behavioral health. It will be fun to kind of see how we can adjust our workflows that are designed for the medical workflows where you have like an MA who's connected with the providers to see how we can best make that work for these different groups, and so that we can expand the number of patients that are screened and through that the number of patients that we're able to support in meeting SDOH needs. Okay, last slide, Emily. So we've dedicated a lot of time and staffing to PRAPARE at Chaz, but I know it's still like it still feels like we're in the beginning stages of this work. We look forward to learning from other health centers that are doing the same work, and I'm always looking for opportunities to share what we've learned with others. And so I'm really grateful for the Bree Collaborative for giving us this platform to share some of our learning, and looking forward to any questions that come up.
Thank you so much, Kylie. This was super fascinating, and it's really great to see all the amazing work that you all are doing. If anybody has any questions for our speaker, please go ahead and raise your hand or place your question in the chat. And while we're starting that process, my question for you, Kylie, though, is how did you begin with like the motivation of your staff to feel like you got that staff buy-in piece where the MAs who already have, as you were highlighting, so many things on their plate felt like, yes, this is important, I'm going to support this, and adding that to their already large workload? I'm curious how you kind of went through that process.
Well, I think it really helped having like our executive leadership behind the work. And like I shared, one of our core values at Chaz is patient-centered care, and I think we talk about those values a lot, and PRAPARE and supporting the SDOH needs it really is that in action. It also helped when we were switching from phase 1 to phase 2 that it was a lot less work for the MAs, which was partly why we made that change. Because it was too much on their end to kind of even keep track of where all the referrals were and all the time spent reconciling the whole screener. And so we were able to shift that from the medical assistants to the community health workers who have a little bit more capacity to do that. But that's definitely, it's been a challenge that we've been working on. And I think partly like some other techniques that we've used is to meet with the clinical staff and to get their feedback and ideas for improvement, and just getting the right people in the room together has been pretty helpful too.
Thank you. I was also curious as you were presenting, you were highlighting that this work began in 2019. Just from my experience and observation, I've been seeing an uptake of social needs screening really occurring based off of the pandemic and observations we made during the pandemic. You noted 2019, which is before the COVID pandemic took place. I'm curious what might have been some motivating factors for your executive leadership or just what you were seeing within your clinic setting that may have increased the buy-in to start this process.
I think part of it is that we, across our system, social needs have been identified or brought up in our clinics, and with our patients specifically, I think it's, for a lot of them, it's really impacting their health. And by not addressing some of these things, it limits how well our clinical teams can impact a patient's health, and just like it just stops it stops the growth and the progression if there's these SUH factors that are in the way. And so coming up with some sort of like systematic plan to try and address that, like our PRAPARE program kind of addresses that. Yeah, and it was also before I worked at Chaz. And
That's
so
okay.
I've heard a lot from staff that it was a bit of like a passion project too, that there are just
Yeah,
staff in our executive leadership that are really passionate about health equity and SDOH needs.
great. I was just kind of curious since that is a different timeline than what I've
Mhm.
kind of observed in other settings. I'm also curious, so when you were highlighting the community health worker piece, uh, did that exist? I think I understood that existed before the social needs screening kind of took place. How has that been built up within your organizations? I think that's kind of a unique space that community health workers are engaged within your clinic system so robustly. I'm just kind of curious if you have any input on that.
Yeah, so we have it's our community health worker team has grown quite a bit over the last couple of years. And part of that is we've recognized that a lot of our patient populations have unique cultural needs that have also come up in our clinical space, and having community health workers that can kind of uh, help guide patients through the medical system, as well as like also informing and sharing information with our clinical teams on how to best interact with those patients. Um, And so we also have, we've had community, well, they weren't exactly called community health workers, but we've had staff doing community health work. And the titles have changed, but for decades. And so it's always kind of been an important piece of Chaz's work. So our first clinic was focused largely with community members who are experiencing homelessness, and so we've had staff working with that population throughout the whole history of Chaz, and now we have a pretty robust community health worker group who does outreach in the community, and supports our. We now have street med and mobile med teams who focus with that population, and so that piece has also grown. And we have, I mentioned too, we have some community health workers from like Spanish speaking Marshallese and Slavic communities. We also have an Afghan community health worker. And so just trying to kind of hire based off of our patient population and uh, what the needs are.
There's a question that just came in the chat with kind of a follow-up to this community health worker piece. They're curious, have you had the 4 community health workers since 2019? And can you speak a little bit on what turnover may be like? Do they have a caseload? And if so, what size?
Yeah, so the 4 CHWs that are primarily assigned to PRAPARE were part of our phase 2. So they've been at Chaz for a year and a half. We hired them because we knew we would need staff to respond to those referrals. And then our turnover is actually pretty low. Um, like 2 community health workers have left our team with the last like 2.5 years, and it's our numbers are constantly changing, and we're hiring right now for another community health worker, but it's like it fluctuates around 20 that we have on our team, and they don't have a traditional caseload. Um, we have care coordinators and who are kind of more like case managers who work with specific patients over time. Our community health workers focus more on a specific issue and then work with the patients until that issue can be addressed. And then patients can always reach out again, but it's not like a longer term partnership. And then our community health workers who do prepare, they're just constantly receiving new referrals as they come in. And so I'd probably say at any given time, they probably have like 15 to 20 that are kind of open, where they're like in that process of like first call, second call letter.
And another follow-up that came in was, are you able to track clinical outcomes of patients supported by the community health workers, or track a reduction in positive prepares over time, like by domains such as transportation?
It's a great question. We are in the process of the data exists in our health records, but we don't have the ability to really look at that or track it. And that is one thing that we're working on, so that we can have more information to support all of the utility of our community health worker team. We have a lot of qualitative data to support that. And we have like the number of appointments and the number of prepare assessments completed, but being able to track those clinical outcomes is one of our goals for sure.
And I just have one more question for you. So you were highlighting in your presentation how there is that questionnaire that you provide, and it's currently only in English, and you're hoping to kind of work on the translation. But then you were also highlighting how your community health workers do really represent your community, and you've recently hired 2 newer community health workers representing some of the populations you're observing. I'm curious, how are you working to ensure the screeners, besides just linguistically relevant, but are culturally relevant in these processes?
Yeah, so we use PRAPARE, which is like it's an evidence-based assessment. And so we don't we don't adjust the assessment in it populates in our EHR, but there is some flexibility with how the questions are asked. We don't require the community health workers to read the assessments word for word, based off of feedback from them that patients really did not like. It was not a positive experience for the patients to complete them, but they had a lot more success and had much more positive experiences when they used more of like a conversational way of asking the questions. We also learned that like it was helpful to introduce the interaction by saying that that they're a community health worker and that they specialize in like social needs, and that they know a lot of the resources in the community and they'd like to connect them with any that they need. And we have this tool that can kind of help us figure out which areas of need that they can help with in that conversation. And so I think that helps too, versus like, I'm here to complete an assessment. And I think that was feedback based off of the community health workers and their interactions with patients. But it is one of the perks. We had been of the perks of having community health workers who are from that community and can ask the questions in their language. We had a really difficult time, like completing the assessment is already, like you can see by our numbers, it's a task. It was even harder when you had an interpreter and you were trying to do all of that at the same time. And so having those staff who can do both of those pieces at once has been really beneficial. And we've been able to increase the number of assessments that we have completed by different patient demographics. So we were able to see before our non-English speaking patients, those numbers of assessments were lower until we were able to add those community health workers who come from those communities, speak those languages, and then our numbers were able to increase.
Thank you. I do
Mhm.
see there is a hand. However, this we need to transition to the next portion of our webinar today, where we are going to have some breakout rooms where you can connect with peers across the state to learn about what they're doing and kind of hear about other work and provide support to one another. So I'm going to open these rooms. You should see an option that pops up on your screen here, and you can go ahead and go into one of those rooms where we will have a staff member. I'm going to resume Welcome back from the small groups. I'm going to invite Carrie to come off of mute and see if you just wouldn't mind sharing one thing that was discussed in your small group.
Yeah, thanks, Emily. We talked about mostly about kind of the barriers to that the individuals have experienced in trying to implement social needs screening. So the people in our group were pretty at the very early stages, and you know, funding came up a lot as a main barrier, I think, for us.
Or do you want to add something that was said in your group?
Yeah, thank you. Well, we had lively discussion, and we were lucky to have Kylie in our group. We talked a little bit about challenges with documentation. And so folks in the Franciscan health system are doing screening, but using a paper document, which has its benefits. I think that interviewers and interviewees sort of were able to complete the surveys better in this way, but then transferring that information into the electronic medical record then, you know, has a challenge, including sort of delay with the process that it, you know, requires scanning of the document and then sort of being available in the electronic medical record, but being in an area that was sort of like difficult to find and not completely having, you know, available for other sort of clinical settings available, for example, like hospital areas and sort of areas outside the primary care space.
Yeah. Thank you for sharing that. And thank you everyone for staying on for our small group discussions. We'll wrap up today, and I just want to thank you for participating. I believe a survey has been placed in the chat, so you can provide us with feedback on your experience attending today and to claim the CME credit. I will also again send out an email with this information next week. We do have a handful of upcoming events, so we would like to extend an invitation for you to join. In a couple of weeks, we are going to have a conversation on the hot topic of metabolic health advancements and equity. We hear a lot about CGMs and GLP-1s and just the equity within that space and how individuals are able to access that and what the implications of their health may be. We will also have a webinar on Catalyst for Change, exploring the analytics at the intersection of equity and value, how we have conversations around value-based care. Is equity centered in that? And how do we use this data information to help inform that work? We, at the end of June, are hosting another learning lab, so like the structure that you observed today, on addressing food insecurity in Washington State. At that webinar, we have a panelist discussions. We have somebody from the Department of Agriculture, DSHS, DOH, and a food and veggie prescription box program located in Skagit Valley, talking about the work they are doing to address food insecurity and how our healthcare ecosystem can work to support patients who are facing food insecurity within Washington State. We would love for you to come and join us in that. And we'll work to wrap up today by thanking Kylie so much for your presentation today. It was fantastic, and I learned a lot from you and all the great work that you are leading with and your community health workers are doing at Chaz. So thank you so much, and thank you everybody for joining us today. We hope to see you soon.